when you have a friend at the chairpersons, you are going to have a generous words for the appreciation. Thank you very much. And thank you, Dr. Bansi and the team of RSSDI and all the persons who are listening to me on the web. Also, good evening to all of you. My topic is strategies for primary prevention of diabetes complications. My disclosures, I have no conflict of interest in talking about anything that I am going to mention. I am a practicing general medicine specialist and neither a diabetologist nor a basic research scientist. So don't expect many statistics from me. And this is how I am going to talk about the what is prevention, different types of preventions, then factors responsible for complications, complications to be prevented, and how do we prevent those complications. We know that diabetes virtually affects most of the organs by the time the patient has 3, 10, 15 years. And what we have learned from the landmark trials like DCCT, ADIC and UKPDS, these were the trials where glucose was the main center of management, and what was the premise for these trials were that glucose is responsible for most of the complications of the diabetes related events that is going to happen. And what we have learned from these trials, particularly the DCCT and EPIC, DCCT was a type 1 intensive versus regular treatment of diabetes in type 1 patients, and ADIC was the follow-up of the cohort of those patients who had taken participations in DCCT. And with these trials, we have followed up as much as 26 years of the control of diabetes, intensive versus the regular. And what we have learned is what we now talk frequently about, the molecular memory and legacy effects. That means if the person is subjected to hyperglycemia for a long time, he is likely to have more complications. And if the person has normoglycemia over a period of even few years, then the chances of complications remain very low. And the overall outcome of these trials were that the retinopathy, nephropathy and neuropathy were markedly reduced, anything from 34% to 76% because of the good control in the intensive arm. And the reductions were solely attributable to the control in the glucose levels. But there are other factors also responsible for complications of diabetes. We need to know the responsible factors, then only we can prevent it. So over and above glucotoxicity, we have endothelial dysfunctions, blood pressure elevations and dyslipidemia, which are further aggravated by the sedentary lifestyle, improper diet or tobacco, alcohol, and tobacco including e-cigarettes now we can say. So what is primary prevention? Primary prevention are the interventions that you carry out to prevent the known complications of the disease as the disease progresses. Have we not done the preventions, the disease would have gone to some specific complications. That is what is the primary prevention. As against that, the secondary preventions and tertiary preventions are once the disease has already shown some signs, some complications, right, even at the molecular level or at the investigations level, if you can prevent the symptoms and signs, that is secondary prevention. And tertiary prevention is we can slow down or stop the complications further, but we cannot prevent the complication which has already occurred. So which complications can be prevented or reduced in the patients of diabetes? Obviously, all of us are interested in the reduction of cardiovascular disease complications like myocardial infarctions or heart failure, which are the most important cause of the morbidity out and mortality out of the diabetes. Then nephropathy, neuropathy, retinopathy, food complications, teeth complications, infections, and pregnancy related outcome because of the diabetes. So these are the all complications which we can control by specific measures. So how early we should start prevention? To me, from the first consultation itself is very, very important. And in the very consultation, we must take the detailed history about the past personal family history as well as the patient's diet and everything. We have to have thorough physical examinations, the weight, the BMI, the food, everything, eyes checkup and basic workup including the HbA1c, lipid profile, microalbuminuria and ECG. And then we have to go for goal setting. On the very first consultation, we should know that what we are aiming at. And it's very, very important that we also look into the pre-diabetic patients, and them also we need to counsel, because we now know that the pre-diabetic themselves are also having many complications of the diabetes. So what is as everybody says, it is the glucotoxicity that has to be attended first, and we have to hit hard and hit fast, and we should try to control as early and as long as we can, avoiding hypoglycemia. That's very, very important, that we have to re-evaluate our glycemic control. Generally, it is agreed upon that HbA1c of 7% or less is the ideal for most of the complications to be prevented. But in individual cases, we might have to relax these targets, and that is why we need to get it over time re-evaluations. SMBG obviously is very, very important, helping us, and particularly in COVID times, it was one which saved us and the saved patients from visiting our clinics. Then CGM and diamine range, our earlier speaker has already talked about it. Now we know that it is a validated tool for the glycemic control as far as in the outdoor settings. In ICU it is still under consideration, but in OPD setting CGMS is accepted, and time in range is that most of the readings, at least the 70% of the readings should be within 70 to 80, 180 milligrams, and only less than 4% of the time should be spent in the hypoglycemic range or time above the range. Which drugs to choose for the control of diabetes? Well, we have a choice of drugs, but it's very important that HbA1c reduction is important. We should avoid hypoglycemia, we should avoid weight gain. So this is what is important when we select a drug. But what ADA says that we must use GLP-1 analogs and SGLT2 inhibitors as far as the prevention of complications are concerned, independent of A1C and metformin use. So we can use other drugs, but we should also use GLP-1 agonist as well as the SGLT2 inhibitors when it comes to the saving kidneys or saving heart. And we should not delay, this is very, very important in the practicing doctors, that we should not delay intensification of the treatment, whether it is oral or IV treatment, insulin treatment, but we should not delay the treatment, what we call is the inertia. We must break away the inertia to intensify the treatment, whether it is oral or insulin, until we achieve the goal. About blood pressure, the blood pressure generally it should be less than 140 systolic or less than 90 diastolic. But if the patient has ASCVD score of more than 15% over 10 years, it is better that we bring down the blood pressure to 130/80, provided it can safely be attained without any side effects of the antihypertensive medicines. And obviously the preferred drugs are ACEI, ACE inhibitors as well as the ARBs, either of them, not combinations. And during pregnancy, the target is further lowered down to 110 to 135 systolic and 85 diastolic to reduce the hypertension associated pregnancy complications. Dyslipidemia, there are few controversies here, but ADA believes that LDL goal should be less than 70 milligram for most of the patients, and the preferred drugs are the statins, whether particularly what we use here are the rosuvastatin or atorvastatin, but the equipotent dose of simvastatin or pravastatin can also be used. There is a specific role for ezetimibe or PCSK inhibitors in select patients, but what is most important is statin for practically most of the patients. And ADA recommendations for primary prevention in diabetes is divided into persons with diabetes with less than 40 years, persons with diabetes with 40 and 75 years, and persons with diabetes more than 75 years. So if the person is diabetic but less than 40 years, and statins are not required if there are no CVD risk factors. But if there is some baseline civil risk factors like LDL more than 100 milligram, or person is smoking, or person is hypertension, or obesity or overweight, then we should start with moderate to high dose statins. What is moderate to high dose statins means? Atorvastatin of at least 20 to 40 milligram or rosuvastatin of 10 to 20 milligram. And if the person has some risk factors, then it's better we go for the high dose statins. And persons with 40 to 75 years, the high dose statins are required to be given in moderate intensity dosages. But if there are overt CVD risk factors, like patient already had either an episode of acute coronary syndrome or underwent PTC or angiography or angioplasty, then we must give high intensity, which may not be the case with more than 75 years, where we go with the lower dose of statins, but moderate dose are required only if there are CVD risk factors. And again, if there are overt CVD risk factors, we have to go for high risk factors. Then aspirin for primary prevention is generally required if the patient has the increased cardiovascular risk and benefits are more than the bleeding risk. So this has to be individualized, and there is no blanket rule of giving aspirin to all patients of diabetes. The lifestyle changes are obviously very, very important, and we should try to maintain the ideal body weight, keeping in mind that the new BMI cutoff point is 23 kilograms per meter square for all our Asians, and the dietary changes should include healthy eating habits and consult nutritionist or the dietitians if required. Exercise, we must tell our patients to do 150 minutes of at least vigorous exercise, and out of this should be 75 minutes of weight training. And now we know that sitting is a new smoking, so we must interrupt prolonged sitting. Every 30 minutes we should get up and walk. Then yoga meditations are good. We must avoid tobacco, alcohol and e-cigarettes too. And we need to have general preventive food care. That's very, very important. Every visit we have to look at the food and tell patients about how to prevent the food complications. Vaccinations are very, very important to prevent the infections, because the diabetic patients are vulnerable to infections and many complications, and most of the hospitalizations are either because of the infections or the kidney or heart related complications. So now we know that all patients need 2 doses of vaccines that we are currently using here. Maybe we will have third dose, booster dose or annual dose, that the time will say, but influenza annual is must. Then pneumococcal vaccine also, at least first dose before 65 years and second dose after 65 years. Hepatitis B primary 3 dosages and boosters after 20 years. Typhoid vaccines every 3 years, and triple vaccines including the tetanus, diphtheria and acellular pertussis. First primary 3 dosages and booster after 10 years. We do not routinely advocate zoster and HPV vaccines, but that is also recommended by the ADA. Zoster vaccines of 2 dosages above 50 years, and HPV, human papilloma virus vaccines under 26 years to all women, 3 doses over 6 months, but between 27 and 45 should also receive as a part of if they are diabetic. The regular physical checkup and tests are very, very important, because that is how we pick up the earliest signs of some complications may be in offing. So complete physical examinations at least once in a year, then annual ophthalmic checkup, which includes the fundus examinations, and now telemedicine for retinal screening is accepted. Then annual dental surgeon consultations. This is one neglected area, and we know that periodontitis is one of the important complications leading to the further systemic infections, including bacterial endocarditis. We must get all routine blood tests, whether it's a fasting or post-renal blood sugar or glycosylated hemoglobin or the renal functions, and sonography for the fatty liver or NAFLD. It's very, very important that we do at least once in a year and have a serial follow-up of the same. Urine for microalbumin is definitely need to be done at least once in a year, preferably twice in a year. The cardiac investigations, whether it's ECG or 2D echo is must, but more thrust is now given to the coronary artery calcium score, because that's a non-invasive and very important way. The atherosclerosis begins with the calcium deposit in the coronaries. So we can go for coronary calcium score and CT angiography. Then cardiac autonomic neuropathy testing along with the other tests for the diabetic foot should be done, which includes the ankle brachial index, 10 gram monofilament test, visual perception test or body scan. So all these things are very, very important, and we make sure that our diabetic patients live longer and healthier. Thank you.